My name is Linnea Olson, and the most important thing you need to know about me is that I'm alive. Thank you. I was diagnosed with non-small cell lung cancer in April of 2005. I was 45 years old at the time. I had never smoked. The only other person I'd ever heard of who was like me was Dana Reeves. And back then, I had what was considered cutting-edge therapy, which means there really was no edge other than the fact that I was tested right away for a genetic mutation. And my very forward-thinking oncologist thought I might be EGFR positive. But I had turned out to be negative for that. I was staged at 1B initially, so I had a lower left lobectomy the old-fashioned way. And I got to tell you, it's a bear of a surgery. And that was followed by 4 rounds of adjuvant chemo, cisplatin and Taxotere. And at that particular time, having adjuvant chemo was a little bit cutting edge, but my tumor was large. It was 5 centimeters. And so my oncologist felt it was indicated. And my hope was that I'd be cured. My youngest child was 7. My oldest child was 19. I couldn't imagine not being there for them. But unfortunately, my cancer came back by my first scan. And so then we just did what we called watch and wait. And by the summer of 2008, I had more than 33 tumors in my lungs. And I was told that I had 3 to 5 months left to live. So my youngest son and I both started counseling. And in a strange way, this period of time was a gift because I came to terms with my death back in 2008. I accepted it. There was no other choice. And as a last-ditch effort, we tried Tarceva. Didn't work, had all the side effects though. And then in August, at my first scan review, my oncologist told me that my biopsy had been submitted for another round of genetic testing, and I was positive for ALK.
Can I ask you, this was when? When was the August of what?
This would be 2008.
August of 2008.
So it was very recently identified, right? As a
Yeah,
driver.
so, I mean, the only reason I interrupted,
No.
Linnea, I'm sorry, because it was in 2007, July, that a group of investigators from Japan tested a tumor of, interestingly, a smoker, and they found ALK as a translocation, as a genetic alteration in lung cancer. What I find, the reason I interrupted this is, in every day when I treat patients with ALK or EGFR, even though you might be interacting with 1 or 5, 3 or 4 doctors and their nurses, and there are probably thousands of people from all over the world who have contributed to the knowledge and to the care that we can deliver now. Because if those investigators had not identified in 2007 that ALK is a translocation, and then those wonderful doctors who were involved in the initial crizotinib trial that Linnea was fortunate to be with Dr. Shaw at that time, I guess, had not decided that we have a drug that works against ALK and decided to proactively start testing lung cancer patients for ALK translocation, none of what has followed would have ever occurred. And I just wanted to highlight that fact.
No, it's significant, and it underscores too that sadly too much of survival is right place, right time. There's some luck involved, and I obviously had come to the end of my journey only to have another door opened. And it's hard to appreciate now what it was like then to make a decision to enter a phase 1 clinical trial, because back then everybody died. and the only other person who had been on this trial at my hospital died in part because of side effects of the drug. But I also knew that I was definitely going to die if I didn't do anything. So I leapt at this chance, and on October 1st of 2008, I became the 4th person in the world with non-small cell lung cancer to take crizotinib. Your turn.
Before I start, I just want to mention that, very briefly, I am at Carmano's Cancer Center, Wayne State University in Detroit, and I've been doing this for 15 years. I see, just to provide you a perspective, I see about 250 new lung cancer patients, about 50 patients each week. I believe I am attached to my patients. I believe that I don't just view them as patients, but as human beings who are dealing with a very difficult disease on a daily basis. But I will say this, that yesterday we had a dinner of faculty and patients, patient coordinators. And Linnea, there were a couple of other patients that I had the privilege of having dinner with, and they never mentioned their lung cancer. We're talking about a variety of different things. But there were very, very small reminders during the dinner that she and another patient who were with us were dealing with this disease. And I'll tell you, I left that dinner with the feeling that how much ever I see patients in the clinic and I really make an effort to realize these are not just patients, these are not just scans that I'm dealing with, these are human beings who are dealing with this disease on a daily basis. It's moments like this that when you spend with patients outside the clinic that you realize this is a lot more than what we are talking about. And I tell you that I genuinely appreciate, I'm not just saying this, I'm thankful for those moments because we as doctors need to realize that. So thank you, Linnea, for a wonderful dinner that I had last night with you. We doctors, it's difficult to develop presentations, at least for me, when I'm talking to patients. And yes, I'm using slides that I normally would present to a set of doctors or healthcare providers. But I'm going to use the slides more as a tool to talk. I'm hoping this is a conversation. Please interrupt me. I sort of started this thinking, what sort of questions would patients want to ask me? And that's what I've sequenced. By no means these are the only questions you would have, and I'm sure this is just a limited set of questions. But I'm hoping in my presentation to answer these questions and of course some of the other questions that might come up. And I've asked Linnea to help to interrupt me if she feels I'm getting too technical, or any of you can, or for that matter, if you feel that I need to explain this a little bit more. So when I see a new patient, I actually make an effort to explain what is cancer. And I feel that I've done this because in the beginning when I started, I met patients and they didn't know if they could give their cancer, like if it was an infection, whether now their wife or children could know it. So I've made an effort to sort of discuss with the new patients I see what is cancer and then what is lung cancer. And I think when we are talking about something like ALK, this is worthwhile. Now, I'm sure most of you are very familiar with this concept, but I just still thought that it would be worthwhile to go over this. So as all of you know, we are made up of something called as cells. These are generally round in structure, and in the tip of my little finger, there could be up to 1 million cells. And in each of our cells, we have 2 sets of genes. One set from our father, one set from our mother. And it's the genes that tell each of our cells what they're supposed to do. So the same set of genes are present in every cell of our body, but only certain cells, certain genes are active. So in the lung cells, certain genes are active and they give a certain set of instructions to the lung cells, and that's what makes it function as a lung cell. In the heart cells, you have the same set of genes present, but only certain genes are active. and they give a certain set of instructions, and that's what makes it function as a heart cell. So we are made up of billions and billions of cells working together under the directions of the genes that we have inherited and the genes that are present in every cell, and that's what makes our body tick. Now, when I say give instructions, what do I mean? These genes are codes for certain molecules. So when a gene is going to be active or is relevant in a particular cell, that gene then leads to a formation of a molecule, and that molecule has a specific function, and that's how the cell functions, and the cell is healthy, and then the body can be healthy. However, during our lifetime, we can pick up damage to the genes. So we think of inherited gene disorders, but even if we have inherited normal set of genes, we can acquire damage to these genes through a variety of things. And yes, I've put smoke because that has been the factor that has been most commonly associated with lung cancer, but a variety of different agents can cause damage to the genes. And so what this is supposed to represent, and please, my PowerPoint skills are very poor, this is supposed to be normal genes, even though there's a break here. And these blue sort of bars in between are supposed to represent that you can acquire damage. Now, when I say damage, it doesn't mean all the genes get damaged. Only some of the genes get damaged, and only in some of the cells. Why only some of the genes get damaged, only in some of the cells, we don't understand. Just to briefly explain the gene damage process a little bit more, let's say you had 3 different individuals, and I'm just going back to the smoking because it gets easier to explain. We all know never smokers get lung cancer, and not everybody who smokes get lung cancer as well. But just to highlight this, let's say you have 3 different individuals growing up in the same area, same background, smoking the same cigarette, same length of time. One person may not pick up any gene damage, let's say in their lung cells. Another person may pick up this kind of a gene damage. A third person may pick up a completely different type of a gene damage. Now, why different individuals, despite getting exposed to the same environmental pollutant, either don't develop any gene damage or develop different types of gene damages? Again, something we don't understand very much. And finally, just because you get gene damage doesn't automatically mean there's a consequence. There's enough redundancy within our genes that the remaining normal genes can provide the normal functions, normal commands to the cells, and the cells can function normally. However, if the gene damage occurred at certain specific points along the genes, the damaged genes start producing molecules that are hyperfunctioning. And these hyperfunctioning molecules make the cells do things that they are not supposed to do. Forget the title of this slide. What this represents is when you acquire gene damage that can cause molecules that make the cells do wrong things, what they make the cells do is they make the cells multiply when they're not supposed to multiply. Our normal cells can multiply, but they only multiply under certain circumstances because the normal genes regulate that, and once they multiply up to a certain number of times, the normal genes will tell them to stop multiplying. But in the cancer cells, the damaged genes just tell the cells to keep on multiplying and don't send in the stop signal. And eventually they develop the ability to form new blood vessels because they also need nutrition like the rest of our normal tissue. And so they develop the ability to form new blood vessels from existing blood vessels, and eventually can develop the ability where some of the cancer cells can detach from the main mass, get into the blood vessels, can travel to other parts of the body and start growing there. Normal cells do not have the capacity to detach from where they are located and go to other parts of the body and start growing there. Cancer cells derive the ability because the damaged genes tell them to do so. So any cancer is our own tissue that is growing when it is not supposed to, and that can develop the ability to spread to other parts of the body when it is not supposed to. Now, it was well recognized for years that cancer is a result of multiple gene damages that result in formation of molecules within the cells that are making the cancer cells do all the things that I mentioned. However, what has evolved over the last 10 to 11 years is we have started identifying, at least in a group of lung cancers, what is called as a driver genetic alteration. So what that means is that there's a specific gene that is the main driver of the cancer. What I mean by that is a gene damage that is causing a molecule to hyperfunction, and that hyperfunctioning molecule is the main driver that is making the cancer cells grow and spread. It would be naive to think that in these tumors that we have identified a driver genetic alteration such as EGFR mutation or translocation, that that's the only gene that is abnormal in that cancer. There are probably other genes that are also abnormal and that are probably also contributing to what I call cancer phenotype, wherein the cancer cells are dividing and progressing. But the primary driver is the ALK or EGFR. So this was what became known over the last 10, 15 years. And as Linnea mentioned, this all started in a way with EGFR. It was back in 2005 that EGFR mutation was identified as a driver genetic alteration. And then in 2007, ALK. And then subsequently, we have identified multiple other what we call driver genetic alterations. And very briefly, what we mean by that is there's a specific gene that is altered. That gene alteration is causing a molecule that is hyperfunctioning. And that molecule that is hyperfunctioning is the primary driver of the cancer, but by no means is the only driver. And depending upon what other drivers are also, what other genes are also abnormal, could influence how the patient does or how the patient benefits from a particular drug. So you have patients who have been on Xalkori for 3-4 years, and then there you have patients who on Xalkori had disease progression in 3-4 months. Why two different ALK translocation positive patients are having such diverse benefit from such drugs is probably because the other genes that are also abnormal may be contributing to the biology of the tumor and therefore the way the tumor is going to respond to the drug. And I hope I've not gotten too technical about this. What this represents, these pie charts, is we are dividing now non-small cell lung cancer into multiple categories based on the driver genetic alteration. And I do want to emphasize that we still have a group of non-small cell lung cancer patients even today that we don't know what their driver is. But in adenocarcinomas, and I'm sure all of you know, in non-small cell lung cancer, you have subtypes of non-small cell lung cancer, primarily squamous cell and adenocarcinoma. In general, in adenocarcinoma patients, the ability to, we have identified the driver genetic alterations in a higher proportion of patients. So I would say in general, in about 40 to 50% of the patients, and that proportion varies from one series to the other, but in about 40 to 50% of adenocarcinomas, you can identify the primary driver. And if you can target the primary driver, what happens is when we say targeting the driver genetic alteration, what we are doing is you're giving a drug that is blocking that molecule that has resulted from the gene mutation. And by blocking the molecule, since the cancer is heavily dependent on that molecule, once you block it, the cancer cannot proliferate, the cancer cannot spread, and it dies. Now, eventually the cancer learns to overcome that. But that's what targeted therapy means. That is, you're targeting the molecule that has resulted from the driver genetic alteration. So what is ALK? And many times you might see the terminology EML4 ALK, and I'll try to explain this. I just want to briefly mention ALK is anaplastic lymphoma kinase because this was first identified in lymphomas. So there's a specific type of ALK-positive lymphoma. So for years before it was identified in lung cancer, it was identified in lymphomas, and this molecule is hyperfunctioning in a small proportion of lymphomas. And so there was knowledge about ALK, but before 2007, this was not found to be dysregulated in lung cancers. ALK gene appears to be relevant more in during our fetal development and in early neonatal development. In general, the ALK molecule that comes from the ALK gene doesn't appear to have a role in adults. It does appear to have relevance in neural development and gut development, but in adults, even though the gene is present in every cell, the gene is not functioning. It is quiet because its role primarily is it during the fetal stage and neonatal stage. And I'll tell you why I discuss that with you. EML4 stands for this echinoderm microtubule associated protein like 4, is another gene, and in chromosome 2, so as all of you know, there are 46 genes, 23 from father, 23 from mother. There are 46 genes, and each of these 46 chromosomes, I apologize, 23 chromosomes from father, 23 chromosomes from mother, and each of these chromosomes are labeled from 1 to 22, and then there's X and Y, which are the sex chromosomes. So on chromosome 2, every chromosome has a short arm and a long arm. It doesn't appear this is long. But 2p, P stands for petite. And so the short arm is called 2p. And in the short arm of chromosome 2, in all of us, in all of our cells, there is the ALK gene present. And very close to it is the EML4 gene. For reasons that we don't know, in ALK-positive lung cancer patients, the EML4 gene, the damage results to that, the damage to that portion of the chromosome results in the EML4 gene being, a portion of the EML4 gene being now inserted into the ALK gene. As a result now, you form a new molecule because, which is called EML4 ALK fusion gene, and this is better represented here. So if you look at the short arm of chromosome 2, the EML4 gene is here, the ALK gene is here, this is how the ALK gene looks, this is how the EML4 gene looks. What happens is a portion of the EML4 gene comes into the ALK gene, and now you have a EML4 ALK gene formed that forms a new fusion protein wherein the ALK molecule, which is not supposed to function in adults, starts hyperfunctioning. The fact now you've formed a new molecule where there is a portion of the EML4 gene and a portion of the ALK gene causes that molecule wherein the ALK protein is hyperfunctioning. What this is showing is how do we diagnose it? It's called the ALK fish test. What this is showing is they have created probes, one that has a green color, one that has a red color, and the probes are to two different ends of the ALK gene. Normally, the two probes are to get too close to each other, as you can see here, because there is no increased gap between the two in a normal gene. But what happens is when you put the EML4 gene now in between the two, the red probe and the red probe and the green probe get pushed apart. So the signal of the red probe and the green probe come from further apart than what they would normally. And that's why it is many times also referred as break apart ALK-positive fish test. And so what they do is they take the biopsy, use these probes to see if in that particular patient's tumor, the probes are far apart than what they should normally be. And I hope I'm being clear in that. Now, any test has a false positive and a false negative. And so to minimize that rate, you have to see it at least in 15 cells, 15% of the cells, and you have to at least count 50 cells. And so what is very important to note is you need to have enough number of cells that you have counted, and you have to see the signal in enough proportion of cells to call it ALK positive. So if you have only 5% of the cells positive, even if there is a positive signal seen, the result would be called negative. I hope I was clear on that. The problem is, because this is relatively close, these genes normally are not further apart. Folks who don't have sufficient level of expertise may not identify the separation as well as somebody who has expertise. What I mean by that is, in other tumors, a gene gets inserted from one portion of one chromosome, let's say goes from chromosome 2 to chromosome 3. When that happens, showing a separation is much easier. When you are having a separation in the same, rather the insertion in the same portion of the chromosome, this is sometimes harder to diagnose if you don't have a sufficient level of expertise. So there's interest in looking at other tests to document whether the patient's tumor is ALK positive or not. And one such test is what is called as IHC. And what that basically means is it is using a dye. So they take the tumor cell, the tumor biopsy material, and literally throw a dye. That dye only sticks to ALK. If the ALK is not present, the molecule is not present in the cancer, the dye is not going to stick to the cancer cells. And so they throw the dye on the tumor. They don't throw, but they try to stain it, and then they wash it off. If the ALK molecule is present, the dye is going to stick to the cancer cells, and it cannot be washed off. If the ALK molecule is not present, the dye is going to be washed off. This is called immunohistochemistry. And the reason why this works is, in normal adult lung cells, ALK is not present because the molecule is not expressed. I told you the ALK gene is not active in adults. And so when you have the translocation, the ALK protein gets expressed, it's hyperfunctioning, it is present on the cancer cells, and that's how you can detect it. And sometimes this turns out to be a bit of an easier test to detect ALK than this FISH test, which is how ALK diagnosis was usually made. This test became approved in the United States last year. The only reason I'm mentioning this is ALK testing, and it's hard to sort of communicate all the technicalities of it. ALK testing might be a tiny bit more complicated than EGFR mutation, and that's simply because, you have a question, sir? Correct. Correct. Perfect. Perfect. And so I didn't get into the antibody part. I just said the dye sticks only if the ALK is positive. If the ALK is not present on the surface, it is not going to stick to it. Okay? Yes? Sorry. So ALK testing, for example, in Japan, they do this test first. If it is positive, they confirm it with FISH. Whereas many places in US either do this FISH, break apart FISH test, or they do IHC. A lot of folks probably will be moving to do IHC and then going on. What the data has shown is whether you detect the ALK by IHC or by FISH, the benefits of the ALK drug are the same. And finally, go ahead, Linnea.
Just a quick question. When you have an oncogene like ALK and you are successfully treated, if you stop treatment, can you ever eradicate this gene entirely from your body, or is it always going to be in there?
So a couple of things. One is, I want to make this very clear. This ALK translocation or the ALK damage gene is only present in the cancer cells.
Okay.
So if you test for the ALK translocation in your normal, if you let's say go and biopsy your normal lung or your normal skin, the ALK gene is going to be perfectly normal. For some reason in the cancer tissue, the ALK gene got damaged. And so that is what is called as somatic gene mutation. Somatic means that is something that has occurred in the cancer, that's not something you inherited. Whereas if you had something inherited, it would be present in every cell of your body. I hope that was clear. So if you biopsy normal lung tissue, you're not going to find ALK in an ALK-positive lung cancer patient. Secondly, these driver genetic alterations, this is not true just about ALK or EGFR. As long as the cancer is there, we, as best as we know, in a high proportion of patients, and in medicine there are always exceptions, the ALK translocation always is present in the background. Now, it is possible that if you biopsy a particular area, you may not, because the tumor has become resistant, you may not detect ALK because a clone has evolved where a different mechanism of, a different gene is altered and that is driving the cancer. But at the core, in all patients, there remain a proportion of cancer cells that have the original ALK mutation, ALK translocation. Now, they may have other gene alterations, either in the ALK gene itself or in other genes. And so there is no question that the longer the tumor survives, in general, the tumor continues to acquire mutations. And that continued acquisition of mutations is what results in the tumors evolving and becoming resistant to drugs that the tumor was treated for. One last thing, because I was talking about testing, and this is relatively new, and this is still primarily applicable in EGFR. We have a lot less data in ALK. And that is, we have always relied on testing for these gene alterations in tumor biopsies, which means they have to put in a needle or do some surgical procedure to get a material of the tumor. But what happens is, as these cancer cells are dividing, certain proportion of cancer cells do die, and they do release tumor DNA into the blood cells. And you can now isolate what this is called as cell-free circulating tumor DNA, and then that DNA can be utilized to do testing. I will tell you this technology is still evolving. Having said that, just this year, this tool has been FDA approved for EGFR mutation testing. This may have more relevance in ALK resistance because it is possible that ALK mutations that can cause resistance to either the first ALK inhibitor or the second ALK inhibitor could be detected. Could be detected by this technology. One important thing to remember is that in general, at least in EGFR, the sensitivity, that is the ability to detect a specific mechanism of resistance or a specific mutation, is about in the range of 60 to 80%. So what that means is that if you don't detect that specific mutation that you're looking for in the cell-free DNA from the blood, that doesn't mean it is not present in the tumor. So it could, many people, at least for EGFR, what they're doing is that they're using the blood test as a screening tool. If they find it in the blood, well and good, but if they don't find anything in the blood, then they go and do the biopsy. But if they do find it in the blood, you can use the blood result to go ahead with your treatment decision. Again, I want to emphasize, this is still not being, we don't have enough data for ALK, but the only reason I mentioned this is likely to come in the future. Now, before we get into sort of the management and how the drugs are used, I just wanted to highlight a couple of facts about ALK. This does appear to be a disease of the young, and I want to be very careful when I say that. Median age of lung cancer in the US is 71. The median age of ALK patients is about 50 to 55. Now, I hope all of you know what I mean by median. It's where if you took a group of people where the 50th person, if you line them up from lowest stage to highest stage, where the 50th persons would be. This is not to say that you don't have older individuals, and also we all have treated 20-year-olds with ALK-positive disease, but what is very clear is that this disease does appear to occur, the age group does appear to be somewhat younger than the average lung cancer patients. The reason I mention this particularly to the trainees is that if I had a 35-year-old ALK patient, I don't care how much they have smoked, 35-year-old lung cancer patient, I don't care how much they have smoked, I'm really going to do my best to test for ALK. And frankly, the Ross population sort of goes along with this. So Alice Shaw, I believe the greatest ALK expert in the world, who's the doctor of Linnea, told me years ago, if you don't find ALK and you're suspecting ALK, test for Ross. The other thing to remember is that, yes, majority of never smokers, but there are patients, even current smokers, who may have ALK positivity. So it's important to test for ALK in all adenocarcinoma patients. Almost always adenocarcinoma, unlike EGFR, where you do see squamous is much less, again, can occur, but much less likely compared to EGFR. I just wanted to highlight the young age group. Another difference in terms of the characteristic feature is there's a definite difference in the rate of EGFR mutation positive lung cancer in Asian countries and in North America or European countries, whereas ALK proportion is pretty much the same across the world. It's not clear why this difference exists between EGFR and ALK, why EGFR is more common in Asian countries as compared to North America. So Linnea already gave you a preview of how this field started. So as I mentioned, in 2007, there was a very famous paper in the journal Science where the investigators from Japan identified this ALK translocation as what we call driver generic alteration in a group of lung cancer patients. Crizotinib was at that time being developed by Pfizer in a phase 1 trial, and I'm sure all of you know, but very briefly, the goal of a phase 1 trial is to identify what is the safe dose. And the way they do this is they do animal studies and define what would be a safe dose to start off in humans, and start off at 1/10 of that dose. So they start off at a very low dose, and then they keep going up until they hit a dose level where patients experience toxicities that are unacceptable. So as you can imagine, patients who are being treated at a very low dose may not see a benefit, even if, let's say, they were ALK positive, because they're not just getting enough of the drug. So this was a phase 1 study being done while this report came out, and this drug was actually being developed by Pfizer as something called as a c-MET inhibitor. c-MET is another driver generic alteration in lung cancer. They knew this is an ALK inhibitor, but it was not being developed as an ALK inhibitor, but c-MET was felt to be a more attractive target because it has implications not just in lung cancer, but other tumor types. When this report came out, several investigators that were participating in this study decided that they were going to test lung cancer patients' tumors for ALK translocation. And as a lung cancer doctor, I'm just really fascinated by the sequence of events of how this evolved. I mean, if the Japanese investigators had not identified ALK, or even if it was identified, folks who were working on this drug had not made the effort to develop a test, because there was no test at that time that could be utilized in human patient specimens to find out if the tumor had ALK translocation. So they developed a test in the lab and then tested the patient samples. And then Linnea, as she mentioned, she was the 4th patient to go on the study. I can tell you there were patients who were treated at 50 milligrams, and a couple of the patients did have benefit. But this shows the dose escalation, and they went up to as high as 300 milligram twice a day, but that was not felt to be tolerable, and then they landed up deciding that 250 milligram twice a day is the dose. So the goal of this trial was really not to define whether the drug works or not. The goal was to figure out what this dose is, and it was during the conduct of the trial that they identified this whole story about ALK, and I just can't get over the amazement as how these sequence of events helped. What this represents is, we call it as a waterfall plot. So this is the waterfall plot from the first trial, and what this represents is each line here is a patient who got treated on crizotinib, and this represents to what degree the tumor shrank, and this is the baseline. So any line above it means the tumor grew, any line below it means the degree, and the longer the line, greater was the tumor shrinkage. So there were clearly some patients in whom there was virtually no evidence of disease seen after they were seen, at least on the initial scans when they're treated with crizotinib. And I'm just going to mention, Linnea explained the story much better than I can ever state, but this is my patient, and why I'm just telling you is, this is a patient of mine who came to me in February of 2010 from another institution. He was a never smoker. He had already been diagnosed with lung cancer for over a year by the time I saw him, and he had already received 3 different treatments. The only reason I'm presenting this case is just to provide a perspective of a physician. I can tell you, when I saw this patient, he was on a wheelchair with 3 liters of oxygen, and I was certain that if we didn't give him any effective treatment, based on the scans I saw, that he wouldn't be with us for a very long period of time, probably even weeks. And as I'm sure all of you know, all this is basically lung. You can hardly see any normal lung. The dark spots are the normal lung portions. The white spots are completely tumor in this patient. And so he had already been treated with Tarceva, as Linnea was treated, because we knew that EGFR mutations were more common in never smokers, and at that time we only knew about EGFR mutations. And so we used to treat every never smoker with Tarceva, hoping that they had EGFR mutation and they had a benefit, but this patient had clearly not benefited. And we sent the tumor off. And I still remember this was one of the first patients I got a positive ALK result. This was among the first patients. This is a scan 3 months later, but I can tell you within 2-3 weeks, the patient was off his oxygen. He actually, within 2 months, went back to work. You have far better stories than this, I know that. Why I'm telling you this is the first evidence that I had of where you identified what was at the heart of the tumor. And then if you could target that, you do see a clinical benefit, rather than giving these chemotherapy drugs that do work and do provide benefit, but are relatively non-specific. And it was this sort of observation that really stimulated me, and I'm sure all the other lung cancer doctors that have been sort of involved in this field. So this was the initial data that I showed you, but what we had to prove is that this is better than chemotherapy. Yes, this was clearly better than chemotherapy, but that's not enough for the FDA to approve. So there were 2 trials that were conducted. One is where crizotinib was given after the patients had already had chemotherapy and the cancer grew back. And that was where ALK-positive patients were treated with crizotinib, half of them were treated with what we would consider at that time as the standard second-line chemotherapy. And then this was a study, the bigger box is of the patients who were enrolled in the front line. So these were stage 4 ALK-positive lung cancer patients who had never been treated with any previous therapy, got crizotinib, half of them got crizotinib, half of them got chemotherapy. And crizotinib clearly provided greater tumor control, and the duration of control was longer. By the way, in both studies, at the time of progression, if patients got chemotherapy, they were switched to to crizotinib. So they didn't look at overall survival as the primary endpoint, because the overall survival could be the same if you got the ALK inhibitor later on. But what this showed was clearly crizotinib was superior to chemotherapy in terms of shrinking the cancer and keeping the cancer controlled for a longer period of time. Go ahead.
I just wanted to point out that a while ago I was looking at a chart like this, And all of a sudden it occurred to me, that's me. That's
Yes.
me at the far
Yes.
end.
And so this is the most important thing. I'm sorry, Linnea, but what she's pointing out is, look at where basically by 15 months, you hardly have anybody on chemotherapy that has not already progressed. This is not survival, this is progression-free survival. Whereas at almost 20, 25 months, you have almost a quarter of the patients that have not had any tumor progression. We all have had patients who've gone out to 3-4 years on crizotinib or Xalkori, and that's also true in the second line setting. I will mention, I think you can see this from the curve, the benefit overall does appear to be better if crizotinib is your first treatment, as opposed to if it, at least for stage 4, is your first treatment, as opposed to you got chemotherapy and then you got Xalkori. That's sort of extrapolating from 2 different trials. I want to be cautious in mentioning that, but it does appear to suggest that if you're ALK positive, you're better off starting off with Xalkori, because the benefit does appear to be somewhat better as opposed to starting it after chemotherapy. Now, there are side effects, and what I'm going to do about side effects is highlight just a couple of things, and then we can discuss if there are specific side effects that you wanted to mention. There is the visual disturbance, and I'm sure all of you are aware of these sort of flashes of lights that people get, but usually it doesn't have any long-term consequence. I can tell you the one thing that was frustrating to me, at least in a couple of my patients in the beginning, is that there is something called as liver enzymes that we measure in the blood. And the liver enzymes can shoot up. And the way the study was designed was that if they shot up beyond a certain level, you had to hold the drug. And I definitely remember a patient of mine where, unfortunately, I had to hold his drug within 2 weeks of starting the drug. And I do believe that he did not derive the benefit that I would have hoped for because we had to stop the drug faster. So one needs to remember that there are certain lab abnormalities. So the patient may be feeling perfectly fine, but the doctor does the blood test and sees certain lab abnormalities that may be found to be unacceptable, and then you have to stop the drug. Then there are certain other side effects. As I mentioned, I'm not trying to ignore side effects. You deal with the side effects on a daily basis, but we can talk about specific side effects. The problem is a high proportion, I would say almost everybody, eventually develops progression. And I will say we are still learning about why this progression occurs. And I can simply say one thing is that think of the survival of the fittest. Eventually these cells are, think of it as a life form. They are trying to survive, and the survival instinct is so strong that eventually it learns to overcome what crizotinib is doing. And what it does in most individuals is it, one, either further mutates the ALK gene such that the molecule that is now formed by the mutated ALK gene can no longer be inhibited by Xalkori, or the tumor just makes multiple copies of the ALK gene. So the amount of ALK molecule present in the cancer is so high that it overwhelms the Xalkori. Or third, it activates some other gene. It mutates some other gene which then activates a different molecule that then is driving the cancer. So the cancer says, you can block my ALK as much as you want with Xalkori. I'm really not dependent on ALK anymore. I'm dependent on something else. It's not clear, one, which patient's cancer is going to evolve which particular mechanism of resistance, and two, what the sequence of resistance mechanism is going to be. So one patient's cancer may first develop an ALK mutation and subsequently may develop a mutation of another gene, or the sequence could be different. And we are still learning as to how these tumors evolve resistance to the Xalkori drug. And then the final issue is that there are certain sites, particularly the brain, that we have viewed as sanctuary sites. Nature has created certain processes to block off certain chemicals from reaching specific organs. There are two organs in the body, brain and testes, that are covered by certain membranes that limit the amount of certain chemicals reaching those tissues. The simple reason is, thousands of years ago, our ancestors used to eat from the ground and would ingest toxins quite easily. So nature evolved a way, the most important thing you need to survive is your brain, and the most important thing you need to survive the species is your reproductive organs. And so these organs have been developed these membranes that limit the amount of these chemicals or these toxins that can reach. However, they also limit the amount of drugs that reach our brain and some of the other organs. And so Xalkari doesn't appear to get to the brain because of the blood-brain barrier. And so you can develop resistance, you can develop progression in the brain, not because the tumor has become resistant to Xalkari per se. It is because not enough of the Xalkari has reached the brain, and so you're not having adequate ALK inhibition, so the tumor is continuing to grow. I hope that is clear. And so these are the pie charts that are created by different investigators. This data is from Dr. Diebel from University of Colorado, where they took patients who had progression on Xalkari and biopsied every patient's tumor at the time of progression, performed genomic analysis, and tried to identify what was the mechanism of resistance in that particular patient. And then they formed a pie chart where in some patients it's ALK mutation, some patients it's that amplification of the ALK gene where you're causing a lot of ALK molecule, or it's activation of other genes that makes the tumor resistance. And there's a variety of ways that these tumors can evolve. So one important thing to remember is that let's say you have 5 different areas that are growing. It is possible that in each of the 5 areas the mechanism of resistance is not the same. And another thing to remember is that in most patients, even when the resistance is developed, there continue to be a clone of cells that are dependent on the original ALK translocation. And so we usually try to not leave the patient off, at least in the beginning, off an ALK inhibitor for a long time. So usually you want to maintain them on Xalkari until you're ready to start on the next ALK inhibitor, because if you stop it, there's a concern, and we do see it in a minority of patients, but we do see what we call as flare, because what has happened is that the clone of cells that are controlled by the Xalkari start growing again. So this is a little more complex than saying it's ALK translocation and then it switches to ALK mutation, it switches to ALK amplification. The tumors develop multiple different mechanisms of resistance. Having said that, we are starting to learn this better and better, and that is being implemented into treatment strategies, but I still feel that further development needs to occur. This is just to show that brain metastases is a problem for Xalkari, and this is data from the original frontline study where patients with brain metastases, they had treated brain mets. So all patients had to have brain radiation before they went on this, the original crizotinib study. We don't do that anymore. But despite the fact that these patients had treated brain mets, as you can see, 20% of the patients had evidence of progression by 12 weeks. This was better than what the patients who had chemotherapy, that the control in the brain was better with Xalkari than chemotherapy. But important to note that 20% within 12 weeks, despite having had brain radiation, had evidence of disease progression in the brain. And by 24 weeks rather, or 6 months, almost 50% of the patients had developed brain progression. So this is just to highlight the fact that Xalkari does work in the brain. I don't want to make the mistake of saying it doesn't, but the activity is not that significant. And this just represents that the incidence of brain metastases continues to increase. And therefore, even in patients who don't have brain mets, I tend to get brain scans done at some regular interval, usually 6 months or so. I want to emphasize this. This is not standard of care, and insurances may decline it. But a brain mets can occur at and longer the patient survives, higher is the probability that the patient is going to develop brain mets. And therefore, I try to scan them as regularly as possible. Is it coming up to 11:15? I can keep talking. That's my problem. So we can take a bit of a break for them to, okay? Okay. Sure. Okay, the one question was, besides crizotinib and alectinib, what other drugs are on the horizon? And I'm going to mention that in the second half. And who does cell-free DNA tests for ALK resistance mutations? Which labs, hospitals, research centers? Let me say this, I don't want to make this a commercial, I want to be very careful. We send this to Guardant Health. They are one of the sponsors of this meeting. There's several other organizations, Foundation Medicine is doing it. At the present time, as best as I know, it's mainly being done by commercial labs. I'm sure there are research centers. I'm sure Mass General is doing it on a regular basis. Probably University of Colorado is also doing it. We are not doing it at our centers, but there are commercial labs that are doing it. But I do want to mention the amount of data we have in ALK is much more limited. If it's okay, let me just quickly go over a couple more slides, and then we'll take a break, and then we'll come back. So very, very briefly, because these patients started progressing, there was an interest in developing drugs that could benefit patients who were treated with Xalkori and that had developed disease progression. And what these folks did was, when they developed these, what we call now second generation drugs, is they tried to see if they could identify at least some of the mechanisms of resistance and develop a drug that can target the mechanism of resistance to crizotinib. So these are the three drugs. There's lorlatinib, of course, and I'm going to talk about lorlatinib, but this slide just shows these three drugs. By the way, AP26113 is brigatinib, this is ceritinib, and this is alectinib. Just to give you a sense, what this means is how much of the drug is required to cause at least 50% of death of the tumor cells that are being treated in the laboratory by these drugs. I just want to first focus on, this is a tumor, these are tumors that have just the ALK translocation, don't have the ALK mutation or the ALK amplification. And as you can see, Xalkori works in these tumors, but you require a relatively high concentration. All the other three drugs that we are using in the second line setting right now, brigatinib, ceritinib, alectinib, are much more potent inhibitors of ALK than what crizotinib was. So just know that yes, these drugs work in the tumors that have become resistant to Xalkori, but at least in the laboratory, these drugs are much more potent inhibitors of ALK than Xalkori was. And this is one of the reasons why there's interest in looking at these drugs as frontline drugs, because it is felt that they may even produce better benefit than Xalkori. Let's take a break here, and then we'll talk about the next generation of ALK inhibitors. If there's any, I'll just stay here. If there are any questions, I'll address them.